This week on the BackTable podcast.
If the president of the European Society of Vascular Surgery, if all the people who do the job all over the world and they are passionate about better outcomes are asking you, we need something better. Philips, we need something better. Perfusion, a software is great, but it's not enough. So maybe Philips will say, if everyone says that, maybe it's time to put some effort. Let's put some people working on it. Let's put some PhD students. Let's put some engineers. Everyone needs to be part of this effort in order to try to, of course, provide better care to our patients, because this is what we studied for, isn't it?
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
This episode is supported by Reflow Medical, makers of high-performance medical devices for peripheral and coronary interventions. Reflow credits much of the company's rapid growth to their physician partners, who spurred the development of successful products like the Wingman Crossing Catheter, the SPECS and the SPECS LP Shapeable Support Catheters, and the Cora Catheter Suite. Solutions that are physician-imagined and Reflow-engineered. For more information, visit reflowmedical.com. And now, back to the show.
I'm your host, Dr. Ali Baheti. I'm coming to you from Tacoma, Washington. My guest today is Dr. Lorenzo Patrone. He's an interventional radiologist at West London Vascular and Interventional Center, and he's the founder of FYA, which stands for Find Your Algorithm. This is a platform based on endovascular PAD and venous management. Dr. Patrone, thank you so much for coming on the show.
Thanks to you, Ali, for having invited me. It's my great pleasure to be here for the third time.
Yeah, I think you officially qualify as a friend of the show. I told Luke Wilkins it takes 3 times to be a friend of the show, so I think you made it.
Do we get a badge? Do we get a sticker?
Yeah. Today, we're going to discuss your article, The Woundosome Concept and Its Impact on Procedural Outcomes in Patients with Chronic Limb-Threatening Ischemia. As I understand, this was a multidisciplinary effort, and I really can't wait to dive into it a little bit with you. Do you want to tell me how you got started with this concept?
Yeah, thank you. It's great to be here to talk about this project of mine. It actually is a project of mine which I shared with many great minds around the world. Essentially, it's putting together 187 different PAD specialists, different PAD passionates. It doesn't matter where they were coming from. I'm talking about the background as interventional radiologists, vascular surgeons, or interventional cardiologists. And it didn't matter where they came from, also regionally speaking. So essentially, there's people from all over the world, from Australia to US to Europe to Africa to India to Japan, Singapore, everywhere in the world. So everyone who actually is passionate about this disease, and many others that probably I don't know and I didn't include, but this is for everyone. It's something that comes out after there was this kind of scandal on the New York Times last year in summer. And I was very, let's say, upset about that. Not just because of the thing, which is, I don't even want to talk about it because it's not my business. I'm not even from the US. I know little about these things. But it's more like the reaction from the Society of Vascular Surgery, which came out with saying, reiterating this kind of hate between specialties, which is like, we are the ones who need to take care of these patients. And this is something like stuck to my mind. For days I was thinking, what can I do? It doesn't me like I couldn't do any statement because, as I said, I'm not into this business in the US, so I can't stand up for anyone. But the only thing I wanted to say, guys, we can do better, and we can do better together.
I love that. So how did you solicit interest from all of these other specialists?
It was funny because it was I remember 7th of August, something like that. And I wrote this editorial, as I called, and I said, okay, I will send to 100 friends around the world. And I sent a Word document, like something, guys, what do you think about this? Would you like to be part of something like this? And, by sending it on the 7th of August, I was not expecting that many people would have come back to me. But I think in a few days, in a week, let's say 90+% of the people came back to me with a corrected draft. So essentially, this was like a strategic error. I sent a Word document. I received 100 Word documents, which was not easy then to be put together in one other document, which became a Google file. So a Google document, which anyone could change, but at least in one single copy. And I sent to other 100 specialists, and they all also, joined very, very happily. And around 200 people were contacted, 187 came back, and many people told me, I was just overwhelmed by the emails. I didn't feel like I was contributing, and I would have liked to be part of it. And only one actually said, no, I don't want to be part of it. So, I mean, if the 0.5% of the people which I reached said no, and the 99.5 said yes, then I'm super happy. And actually, then we went together. It was a long exchange of emails, but we published it together. And that's our pride.
Wow. So you had this giant Google document that you guys were all editing at the same time. You're basically like Wikipedia, right? And you have like all of these guest editors coming in and making changes at the same time. That sounds really, really unwieldy. I'm impressed that you were able to spearhead that.
No, I mean, like it's the biggest challenge was to change, to take all the 100 initial drafts into one document. That was a challenge.
Tell me a little bit about what a woundosome is for the uninitiated.
Yeah, I mean, it's an interesting concept because I came out with this name while Montero Baker, without me knowing it, already used it since quite a not a long time, but already used it. Essentially, when I got in touch with some people, of course, this was an idea which was in my mind already, and we found out that more or less, despite not knowing what each other was thinking, we were actually thinking the same way. So essentially, we're thinking, I think that when you do a critical limb ischemia patient, or any kind of advanced PAD from the rest pain to the ulcer gangrene, Rutherford 4 to 6, especially when you have an ulcer, you need to go for that ulcer. So patients with Rutherford 5 and 6 deserve a very good study of the anatomy of the foot, and they deserve to receive the best inline flow to the ulcer, which is possible. And if this is not possible, because it's not always possible, yes, we have some magic in our hands, but it's not always possible. We need to try to understand either if we did a good job or either if we didn't. And at the moment, there's no much objectivity on that. So yeah, I've done well. And the same intervention, someone else would have said, no, it's pretty awful. And the opposite. So there's a lack of standardization of the below the ankle arteries, first of all. So essentially, people don't take the images that are needed in order to understand. And even if they do, it's very difficult to quantify how much you change the delta of perfusion at the level of the wound, which actually what we want. We want the perfusion to reach the wound and the wound to granulate. So the patient is released from the rest pain and the wound is healed.
So you mentioned that people aren't taking the requisite views. In your mind, what are the requisite views to properly evaluate a below the ankle wound?
Yeah, that's a very straightforward answer. There was a paper published in 2011 by Marco Manzi and his group. And this paper is amazing. It's on radiographics. It was free since, for years and years. Now it's not anymore. But anyway, there are different ways to get these papers. And I strongly, strongly suggest anyone who is in this business to download it. Because this is it's the perfect resume of the views that you need to take in order to evaluate a critical limb ischemia patient foot. This is of course, we have all the lateral view. The lateral view is the one, first of all, needs to be taken properly. It visualizes very well, the course of the anterior tibial going to the dorsalis pedis and the lateral plantar bifurcating to the medial and the lateral. But then when it goes to the foot arch, let's say even in a sort of healthy foot arch, it's very difficult to understand which metatarsal artery is coming from where. So instead, if I turn the C-arm towards an AP view of the foot, which means angulating the tube in order to have all the metatarsal bones separated and a cordocranial image in order to differentiate very well all the different bones, this is where you understand the anatomy, especially if it's a bit complex, if there's not a straightforward anatomy, and you understand the wound and its own vascularity. Because if you see, for example, there's a first metatarsal artery coming off from a branch of the peroneal, or even better, if you see the medial plantar artery going to the first toe, then probably if you recanalize the posterior tibial artery, then you have done enough. So you need to study. Every patient is different. We know that there are different anatomies, different variations. If you don't study them carefully, we will never go anywhere. I'm even surprised that the European guidelines are saying you need to take an angio which includes the food. Like, guys, I mean, if we're not eating the food, it's like, I think you don't even say it. But if they felt the need to say it, that means there are many people who don't even take a picture, angiographic picture, of course, of the food. So we are so much behind compared to what we should, and there's so much work to do in terms of awareness and in terms of understanding the anatomy better.
Fantastic. Coming back to the topic of the Woundosome, how difficult was it to manage all of these people sharing their opinion and creating this shared paper?
Yeah, I mean, that was a bit of an effort, but I have to say that it's less difficult than what you can think, because essentially, more or less, and I was surprised, and of course I was glad to be surprised, more or less, these old people think alike. So essentially, everyone says, yes, there is the need of a better understanding of what we do. There's a need of a better consideration of the below-the-ankle circulation. We have seen the best CLI trial, the Basic 2 trial. They don't take in consideration the below-the-ankle flow. How can you heal a wound, even if you recalize the anterior tibial, if there's no dorsalis pedis? There's absolutely nonsense. So if we don't divide the patients who have or where a recalization of the foot arch or the metatarsal arch, or anyway, the inline flow has been achieved, and we separate these people to the ones that were, endo was not very successful, because you can do a great revascularization of the anterior tibial, then there's a desert foot, and there's no flow going to the wound. So if we don't differentiate that, if we don't find a classification which goes even over the Cavarada classification, which is, even if is already something which is considered quite complex, to me and to all the other people, is quite simplistic. If we don't go a bit further in understanding which are the connections between the different vessels, if there's a connection with a vessel more than 1 millimeter, if there's a connection made of capillars, of course the flow completely changes. And we need to be aware of that, because we need to be aware if we did something good, if we need to come back. And this is where also the redo procedures is not always a failure. Is that you stage the procedure, but you stage the procedure because you understand that you need maybe to act in 2 different times. So understanding is at the base of acting, I think.
That makes sense. That makes perfect sense. Question for you. Did you face any pushback from vascular surgeons when you were coming out with this concept?
Absolutely not. Actually, I had the full support of any specialist from all over the world. I didn't feel any resistance from anyone. Everyone was very much aware of this problem. Even if I criticize in a way the best CLI trial and the Basic 2, both the main authors who were talking about, Matthew Menard, Alec Fabb, everyone like Andrew Bradbury, and everyone came back to me saying, you know what, you're right. And we have the possibility, and we have the, let's say, the duty of investigating better the images that we receive from all the centers in order to understand and to go with the Woundosome concept in our mind, in order to understand if it's not just endo versus surgery, is in a way correct endo, correct result with endo is worse or better than surgery, without, putting too much fuel on the fire. There's not something which is better than the others, but at least we understand which kind of endo is really successful, when we can be, happy because our endo was actually making a difference. And so no one really opposed to the concepts. Everyone they were, of course, sometimes a bit naive. So I say, yeah, for all the patients, we need to achieve the best inline flow. Many people said, yes, you're right, but try to moderate your way to express yourself. Try to understand that it's not always possible. Try to understand that, even a good collateralization could be very fruitful. But until we don't have a way to measure this flow, it would be always my experience against your experience. So it's very subjective way to judge a flow to the wound.
We've talked a little bit before about different methods for assessing the success of your revascularization on the table. We've had Jill Somerset on the show quite a few times to talk about PAT. Can you tell me what you personally use in your lab to assess the flow at the end of a case?
Yeah, that's a great question, because actually this is the main, probably I would say the main target of this paper is to make awareness about below the ankle recanalization and flow, but also to try to understand, if there is the need of something more in order to evaluate our flow. So, and actually, this is what it came out from the experience of everyone. If we rely on angio, I mean, of course, there are cases where if you recanalize the inline artery to the wound, it's bloody obvious that we did a good job. But there's so many scales of gray in what we can achieve. For example, if we recanalize the SFA pop, which is occluded, and we rely on a single peroneal runoff, maybe giving branches to the anterior circulation or posterior circulation. In that case, we need to understand if the need of recanalizing an occluded anterior tibial artery or posterior tibial artery is there. So is there need to do something more, to lose other, 60, 90, 30 minutes in trying to do something which possibly could not be necessary? And then some people say, yeah, I try to recanalize as many vessels as I can. Some people say, no, we'll stop with a little gentle angioplasty of the tippy trunk and then I stop, because that's definitely enough. So we need to objectivize. And when you mentioned Jill Somerset, I think she is doing a great job with her group in order to understand if what we did is enough. And the PAT, the pedal acceleration time, gives you this kind of information. So going to the wound artery, is the flow, is the peak, the systolic peak, fast enough in order to promote healing? Is the patient after our revascularization falling into class 1 or 2? That's the question. I mean, of course, this is every time we talk about any technology, I think the easiest for any clinician is to get a technology which is reliable, of course, which is cheap, which doesn't cost much, and which is applicable to every wound, in this case, by any operator. So I think that PAT is definitely the new kid on the block. It will stay there. More and more people will be trained. Jill is doing a fantastic job. She's a kind of gypsy magician who goes everywhere and try to really to engage people one-to-one, which is what you really need. But it's a long job. Despite I love PAT and I do it myself, especially for these patients, as I said, the one with a single vessel peroneal runoff, I do PAT for all my patients. I think that's still, despite she says no, but I still think so. There's a little bit of skill set that you need to have in order to get to that good level of prediction. So in my dream, there's a sort of a pin, a sort of a little sticker that you put on the wound, or just on the edge of the wound, and this sticker will tell you if what you have done is right or wrong. Of course, there are many technologies which have been around, and I want to mention two mainly. One is the microsensors, which actually was a way to evaluate the flow. The thing is, these sensors were implantable and were thought to be there for a long time in order to tell you if the flow within the time was still enough. So they faced the problem, from what I understand, especially from Miguel, who was my senior author. So, we are in this together for sure. That the need for implantation was a bigger drama than, because to implant something, especially in an infected wound, was a problem. So from what I understand, and then I'm happy if the CEO of the company will then call me and will say differently, the company lost interest about this. And they just switched all their technology towards understanding the glycemia into the blood. So essentially sensors like Abbott has, to be put on the skin and to, for people with diabetes to understand the level of glycemia. And, together with that, this was the past, and the future could be the PEDRA. PEDRA is another technology which comes from Singapore, actually. I personally know the chief medical officer, who was a great guy from Cambridge. And this system, again, with 3 different stickers, at least they claim, because it's not still proven by clinical studies, just preclinical in healthy patients. They claim that they can measure the amount of flow received to a certain territory, and this flow is measured before, intra, and post-procedurally by these 3 stickers. So essentially, I've seen very interesting images with the balloon, for example, inflating, and when the balloon is inflated, all the, curves assessing the hemodynamic flow are falling down. So essentially, it's pretty interesting, but we're still, at least I'm not involved, but I'm still waiting for more clinical data with this technology. But it's a field that probably needs a bit of push, because there is need, but if you don't shout, probably people don't hear you.
Yeah, because, there's an alternative, right? There's an amputation as an alternative, which bills for somebody, but might not be the right thing for the patient. But I think that's definitely something I struggle with in my own practice, is knowing how much is enough, what I should treat, if I've done enough by recanalizing one or if I need to go after a second. So I'm really excited to see these technologies move forward.
Yeah, I mean, as I said, the more they are cheap and the more they are largely applicable, the more they will be successful.
Could you give me a case example that describes the techniques that you're discussing in this article?
So yes, I think it's a great case because it's not like it was particularly difficult to recanalize these arteries, but it was very important to understand what was what. So this is a case that you can see very well here. There's a pretty obvious foot attack. Essentially, there's a second toe which is necrotic and infected, and you can see also that the infection spreads to the forefoot. And this patient, as any other patient of our centers, go to duplex ultrasound, and the duplex ultrasound was pretty clear. It was saying that the anterior tibial and the peroneal had a triphasic flow to the distal level. So triphasic means perfect. So if you have already two vessels going down to the foot, and one is the anterior tibial artery, which following the angiosome concept is the one giving flow to the second toe, I think you're pretty okay. And the PTA, so the posterior tibial artery, has just closer to 50% stenosis, but patent to the distal with strong pulsatile signals. So essentially, this is a pretty healthy foot. This patient was 57, so essentially you can say, we can go for an amputation, and we decided to go for an amputation, and this was the result. After 1 week to 10 days, there was no improvement at all. And actually, I would say that the wound was open with no granulation and the foot was at risk. So essentially, I pushed to go over the duplex, let's say, and to do an angiogram. You can see here, this is the angiogram. You can see the lateral view on your left side. And on the right side, there's anterior-posterior view of the foot. Now, I can understand that for some people, it could be a bit difficult to visualize vessels. So I will use colors in order to let you understanding what the anatomy is here. So, if you look at the left side of the screen, as I said, the lateral view, you can see the anterior tibial artery. And the anterior tibial artery is going straight down to the foot arch, am I right? But look at the anteroposterior view of the foot. You can see that the anterior tibial artery doesn't go anywhere towards the foot arch because the anterior tibial artery should have gone roughly here. But here, we don't have any flow going down to the foot arch. And we can see that the posterior tibial artery, it's here, on the left side of the screen with of course the purple line, and here again. And the posterior tibial artery gives two branches. One is the medial plantar artery, which you can see here. It's always the one on the top of the bifurcation on the lateral view. And it gives this branch, which is still the medial plantar artery in the anteroposterior view of the foot, which gives very good flow to the first toe. And that's it. And then you can see there's only a thread-like collateral. You can see the two lines coming together on both projections, which gives flow to this vessel. This vessel is the lateral plantar artery. And this lateral plantar artery is the one which gives flow to all the toes. In this case, it's what is called a plantar dominance, which means that the whole flow is brought to the foot arch by a missing lateral plantar artery. And the missing lateral plantar artery is seen here on the screen. So our revascularization effort should be to connect point A to point B in order to give direct flow to the foot, direct flow to the wound, and to heal and save this foot. So what it was done, of course, the evaluation of the anatomy always need to be in our mind, but it's not just defining the variation, just to understand the direct path to our foot. So essentially, this was done with a long sheath, with the Armada XT balloon from Abbott, and then I pushed my O14 command wire into the lateral plantar artery. This is where essentially I land at the level of the Woundosome target artery. I did an angioplasty with a 2mm balloon. And you can see here, this is before, and this is after. And it's cool to see, the two images on the lateral view, but it's also even cooler to see them on the anteroposterior view of the foot, because you can see now that this wound is finally reperfused by a reconstituted lateral plantar artery. And you can see here now the blush at the level of the wound. And despite I'm an interventional radiologist, I always like to show images of the foot. And of course, I'm making a joke here. And here we have the foot as it started, as you have seen before. And this is the progression of the foot granulating better and better until complete healing. So this is the case. Actually, the case just proves that you need to study the anatomy of every single patient in two projections in order to understand what's more convenient for that clinical scenario. And once you've done that, finally, you can act, and then you can do your best in order to, of course, provide a better flow to the patient.
Such a great case. I I learned so much from your cases. Thank you for posting them and sharing them and talking through them like I'm a fifth grader. I really appreciate that. It's super fantastic. It helps.
No, but I think, there are many people, Ryan, that's, probably are passionate, but it's difficult to find actually someone who teaches you all the anatomy in little details. Because, the few people who understand, they sometimes talk between each other. They know the stuff that you're talking about, and don't consider that someone like me, when I started my business, vascular business, you can't talk about business in Europe, but let's say in a scientific way about critical limb ischemia patients, I knew nothing. And I had to go around and try to check, ask, and, I had to get all the information from different sources. And sometimes it was difficult to access. Now, with this kind of new methods, like BackTable is a great tool. All this connection should be very fruitful. People should have more possibility to access this material. And, the more I can share and the more I learn from stuff that other people share, the better it is. So thanks for BackTable.
And thanks, Dr. Patrone, for teaching us about this important concept. What do you think are the future directions of research regarding the Woundosome and regarding this multi-specialty cross-collaboration?
Yeah, these are two different things, and both of them are very important to me. Essentially, I think that we realize firsthand that this kind of collaboration can be fruitful, can generate a lot of discussion, can really change people's minds in many ways, I'm sure. And essentially, I hope that this kind of first paper, which puts together all these experts, will be just a first step of many others. Maybe, focus on the Woundosome again, trying to do another step forward, or maybe on something else. But essentially, also make people connecting, make people feeling that they are not alone in this. They can be friends. And friendship can go across different countries and different specialties. This is what I really care. And what I care also is about research. So research there's a need. So finally, no one can tell, oh yeah, I know, I have a device I want to create, but probably there's not enough market. It's not enough fancy. I want to make enough revenues. This paper is like shouting, there is need of technology to assess the perfusion of the foot. Because if the president of the SVS, if the president of European Society of Vascular Surgery, if all the people who do the job all over the world, and they are passionate about better outcomes, are asking you, we need something better. Philips, we need something better. Perfusion software is great, but it's not enough. So maybe Philips will say, if everyone says that, maybe it's time to put some effort. Let's put some people working on it. Let's put some PhD students. Let's put some engineers. Everyone needs to be part of this effort in order to try to, of course, provide better care to our patients, because this is what we studied for, isn't it?
Yeah, that's all what it's about, is patient care. Just a couple curious technical questions for you. When you do your access, you almost always do antegrade ipsilateral, right?
Depends when it's we're talking about BTK, and also let's say dedicated BTK study for patients with diabetes or other pathologies. Of course, I do an antegrade. With an antegrade access, you are able to do any kind of rendezvous, foot arch recanalization, better pushability through disease distal vessels, and it's very important for me to have like 2 or 3 tricks. One is to put a long sheath. The long sheath, essentially 45 is the minimum. 55 and 65 will allow you to introduce the sheath inside the tibial arch that you want to recanalize. So essentially, if it's a difficult recanalization, especially the anterior tibial artery, you need a strong catheter, strong sheath into the origin of this vessel, because if not, every effort of introducing a wire and pushing a balloon will always be lost at the level of the origin, like protruding into the TP trunk and jumping into the popliteal. So essentially, my strong suggestion is use a 55 or even a 65 in order that you can position it where you want. You can position at the level of P3. Also, you can enter the vessels, because the more the support, the better it is. This is one thing. Also, the other thing is to inject into, first of all, from the long sheath. You will see that completely different images. If you are worried about the amount of contrast you can give to the patient, don't use contrast diluted. Just use less contrast each injection. It's better to inject 4 milliliters of neat contrast compared 8 milliliters of 50-50 with saline. makes no sense to inject such a good amount of liquid when the flow actually is pretty poor usually. So that's another thing. The third thing is inject selectively. Go with a catheter and inject into the vessel, which could be the BTK vessel. Essentially, sometimes you can see microchannels that you can't see if you inject randomly at the level of the popliteal, or even worse, at the level of the common femoral. And try to chase also the below the ankle vessels. Sometimes we have what you call sleeping vessels. You inject the level of dorsalis pedis and you see that the foot arch actually is not as diseased as you think. It's just underfilled because, collaterals don't bring enough flow to the dorsalis pedis or whatever, lateral plantar, and you see a foot arch which looks diseased, but it's just empty. It's like a bag. You need to fill the bag with good blood, and then you will get a good blood shopping, let's say.
So I did hear you say that you kind of use the Armada XT as your as a crossing catheter. That's just a 014 balloon, right? That's that really tiny 014 balloon that Abbott makes.
Yeah, essentially, I like to use this balloon. First of all, because it has a profile which is, despite I have no conflicts of interest in this interview with Abbott, but it's really crosses where nothing else can cross. What I really like from this is just crossing catheters. It's not a micro catheter. There are different great microcatheters. There's the CXI from Cook. There's, the Navicross from Terumo. There's other catheters like the E-Long from, like different companies producing different microcatheters. But the balloon also allows you to potentially dilate a little bit the space where you can't really enter in order to create a shoulder to advance then another balloon. And I think this is very important. And we are studying this space very closely, and we're about to publish a nice paper with the group of Bilbao, Agustis and Marta Lobato. I'm very good friends with them, very good friends of mine. We even when I do cases, sometimes I give them a call or they give me a call. We do a quick video call and say, what would you do here? What would you do there? Then we discuss. It's amazing. Technology gives you really a lot of possibility to connect with people from all around the world.
Yeah.
But apart from that, we are publishing, like, for example, this paper where we are puncturing the below the ankle or below the knee vessels antegradly in order to snare the wire from the foot arch to connect, as it's a bit technical, but the bed form technique is when you connect like a torpedo or something like a torque at the level of the hub of the balloon in order to connect the wire to the balloon, and then you pull the wire, and because by pulling the wire, you pull also the torpedo that you have attached to the wire and connect the balloon, you also pull the balloon through the foot arch. We've done a case together in Pamplona where I was invited to do a very challenging case where the local team failed twice. And actually, it was amazing to see how this effort and this kind of prolonged procedure brought to a complete healing of a wound which was on the calcaneus and which was probed into bone. So really, we saved a limb. I don't know if we saved a life, but we definitely saved a limb. So essentially, we are trying to discover, to push the boundaries for this region, which is definitely under investigated. And together with many other people, we are trying really to progress towards a better wound healing, a better limb salvage rate.
Well, Dr. Patrone, you're just one of the most engaging and inspirational folks out there treating in this space. I'm just so lucky that I got to talk to you and pick your brain about this concept.
Just lucky that you're interviewing me. I'm very passionate when I talk about this stuff. And I got despite here it's 11:30 in the night, I'm still very active and very, let's say, positive and passionate about this topic, because it's really, I think there's really need of people being passionate and share this passion in order to progress in this field, as I was inspired by many. So it's just a change, Oh,
thank you so much for coming on the show.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and Digital Marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manveer Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra.